As we look at the difference between interdisciplinary and integrative, it really helps to back up the train, so to speak, to see what words actually mean. In the years of attending PAINWeek and working Monday through Friday, we actually have seen ourselves go from multidisciplinary to interdisciplinary, and then there's that 2.0 version where our medical home model, putting a spin on how the patient should be at the center of care. Integrative care actually moves into that patient-centered model with a more life perspective at healthcare, and that is quite a journey that we have made in transitioning that for better patient care. Well, one of the prime disadvantages or obstacles to full-blown integrative care, who's going to pay for that? And where do you get those resources? And well, I'm in a rural area versus a suburban area versus an academic intercity hospital with tons of specialists and resources. And then you have your record system. Are you paper? Are you electronic? Do you have an electronic record system that bridges all of these spectrums of practice and specialties so that they can have a collective patient-centered look? And where does the patient visually come into play? Is this telemedicine? Is this video-on-demand medicine? Is this a day-long facility group? Or how is it consultative? How did the appointment generate itself, and who's on duty today that we might assist this patient to save a return visit? How did the consult come to the pain clinic? So staffing, review, environment, payer, it really does take a village to up the ante on the standard of our healthcare for the patient to become engaged with their care and to see it as a life focus and not just a symptom. To speak through and meet the primary care practitioner where they're at, most primary care physicians being in the community. Personally, I'm in the federal government, so I'm blessed with the best the taxpayer dollar can provide. And for those who are taxpayers, the healthcare system is transitioning to the whole health model. And so primary care, in this abbreviated pressure cooker of a schedule that they have, seeing 20 and 30 patients a day, having recalls and new patients interwoven in their schedule day to day. The medical home model brings resources to that. They have nurse care managers, nurse care coordinators. They have pharmacists embedded in the clinic, psychologists embedded in the clinic, social workers embedded in the clinic. And so together, often starting the day with a huddle, for instance, every player knows their role. PDMPs are ready. We know who's coming potentially with infectious situations, who is a pain situation. And so primary care is immunizing, they're preventing health problems, they're trying to manage comorbid situations, and we also have that dimension of the emotional situation that risk stratification can often help us guide treatment plans towards. So primary care being in short supply, by the way, also in the community as well as other healthcare arenas, this is the frontline clinician who needs this support structure, and payers need to be able to recognize that. Billing codes need to change, so to speak, and the insurance providers who decide what we can and cannot have when we become a patient even, it's got to also change to meet these new, better standards to patient-centered care, which is something that I think that the VA has really taken to task and provided. I can just share with you briefly that I also have been given the humble honor of serving on the HHS Task Force for Best Practices in Pain Management, and we're diligently working on this, coming up with a recommendation for Congress on a very short timeline because of the CARE budget and funding and the tasks set forth from President Obama through to President Trump. And so PAINWeek, trainings over the years, my practice as a clinical pharmacist in the VA, just a number of things aligned, and the professional organizations for physicians, for pharmacists, for physical therapists, psychologists, they're all working to raise this bar for us as individual patients, not just the clinicians too. So I just don't want people to think that pain equals opioid. No one really sees that as being the model, and somehow fake news and other unrealistic portrayals of us, we're having to be browbeaten, and yet we're still on the front line taking care of people because, you know, that's the right thing to do.